heart failure, wherein there are several causes that could lead to that condition. So if you recall, the definition of heart failure is a state. It is a condition wherein the heart fails or it is ineffective in doing its job. So the pump is ineffective. So here in acute respiratory failure, this is also the same. There are several things that can lead to it. So when we say acute respiratory failure, it is a state rather than a disease. So for instance, if you had a patient with a PE and then they did not receive adequate treatment promptly, so they could go into respiratory failure. The definition of respiratory failure is, thank you for reading this whole section here, because there are three conditions, actually two, because the second bullet says or. Can you read this, please, Miss Alexis? Miss Williams? Or let's try Mr. Rodriguez.
Read the highlighted?
Yes, please.
Partial pressure of arterial oxygen less than 60, hypoxemic / oxygenation failure, or partial pressure of arterial carbon dioxide more than 45, occurring with acidemia, pH 7.35, hypercapnic / ventilatory failure, and arterial oxygen saturation less than 90% in both cases.
Okay, so there are two conditions here. Either the patient has a PaO2 of less than 60 and oxygen saturation of 90%. That condition is present in oxygenation. I'll explain that. Or it can also be a PaO2, PA of more than 45, and the oxygenation is still less than 90%. However, in respiratory failure, they do respond to oxygen. So that's the good part of respiratory failure. It's a state, meaning if you reach this state, let's say you admitted a PE or pneumonia or COPD, pulmonary causes, we'll look at, there's two tables that follow this page. There are conditions that lead to it. There are pulmonary causes, there are also non-pulmonary causes. So when we say the first type here is ventilatory. So ventilation, what is ventilation defined as? Ms. Martin, what is ventilation?
You want me to read something or just tell you?
No, just tell me, how do you describe ventilation?
Ventilation.
Yeah, go ahead.
Ventilation.
So when you say ventilate somebody, or you are ventilating, you are
giving them oxygenation.
So what are you doing when you are ventilating? You are breathing, right? So you are inhaling and, right, very good. So you are inhaling and exhaling.
Inhaling and exhaling, yes.
Right. So ventilatory failure is a failure of that mechanism, meaning the patient either cannot take in oxygen or they cannot get rid of carbon dioxide. So if you have a ventilatory failure, you have a list here so you can easier to understand. Look at this table, 32-2. So column 1, you have extrapulmonary causes, meaning nothing to do with the lung. Whereas right side, right column, column 2, is intrapulmonary causes. So let's look at the extrapulmonary causes first. So when you have these conditions here, what happens to your ventilation?
It's impaired.
All right, so what happens to the rate and the depth of your respiration when you have myasthenia gravis, Guillain-Barré syndrome, polio. This polio here is polio of the lung, not polio of the leg. If you have spinal cord injury, all the way down to kyphoscoliosis. So what happens to the rate and the depth? You know, how deep your respirations are when you have these conditions. What happened?
I would say the rate would be less.
And the depth is?
Basis.
Deep?
Deep, yeah.
Will you have deep
No.
respiration when you have
No.
myasthenia gravis or Guillain-Barré syndrome?
LD.
Shallow. I think it will be shallow.
All right, very
Oh,
good.
yes.
Yeah, so the rate here will drop as well as the depth. So the patient has shallow breathing and the rate also will be less than 12. So same thing here, look at opioid overdose. Okay, so if you have opioid analgesic overdose, for instance, or benzodiazepine overdose, okay, so all of these, massive obesity, okay, sleep apnea, you stop breathing, right? So all these affect the rate and the depth of your respiration. Same thing also on the next column. Next column, COPD, PE, pneumothorax. So this will affect, although in a pneumothorax, for instance, it may be just one. Because in pneumothorax, you may have increased rate, but then the depth will be shallow because there is now positive pressure in the pleura. The lung cannot expand, the lung collapses, so the depth will be affected. I'll explain ARDS next week. That's our next topic after respiratory failure. So here, this is a failure of oxygenation. That's why this falls under the second bullet. So this will result in a hypercapnic or ventilatory failure, because if the rate and depth of your respiration drops, that means you're likely to retain CO2. You need to be able to exhale fully. So if you can't do that, then of course your CO2 levels will rise and you go into respiratory failure. And let's look at the oxygenation type. The oxygenation failure, this one is a gas exchange problem. Okay, unlike in ventilatory, wherein it was there's no problem with the lung technically in ventilatory failure. If you look at table 32-2, especially the first column, there was nothing wrong with the lungs there. It was something mechanical, something extrapulmonary, resulting in the decreased rate and depth of respiration. Here, the problem is in the lung. So there is a gas exchange problem here. If you look at let's look at the causes. That way it's easier to understand. So here in 32-3, you have problems here that lead to a gas exchange problem. It may not technically be the lung, but then there's an inability to, or let's say there's no available oxygen, such as in high altitudes, for instance, you're in a closed space, or let's say just a bar, for instance, wherein there's so many people smoking, for instance, or you're in a burning house, for instance, wherein there's smoke all around, less oxygen, or in a pneumonia. No matter how much oxygen we give you, there's fluid in your lungs, so there's no gas exchange possible. Same thing with a PE. We may give you oxygen, but there's no perfusion. There's a mismatch because there's obstruction of one or more pulmonary arteries, and then we can go on. A shock, although shock is not respiratory, but because there's a problem with the oxygen delivery now, the transport is the problem. So either way, all of these will still result in low oxygen level. So this one falls under the first bullet of PaO2 of less than 60. And both of these conditions, of course, will result in a low SaO2. Any question on the condition of respiratory failure? All right, very good. So it's a state, okay? This is not a primary disorder, meaning when you're admitted to the hospital, you still have these as your main diagnosis. Let's say you're here for a myasthenic crisis or a cholinergic crisis. If you remember, this was last semester, correct? Myasthenia gravis and Guillain-Barré?
Mm-hmm.
Yeah.
Okay, so if you remember there, the patient is admitted with these, but then one of the complications is respiratory failure. So now your diagnosis becomes Guillain-Barré syndrome with respiratory failure now. The easy thing about this is the intervention. There's only one intervention for respiratory failure, and that is oxygen. So you simply give oxygen because these patients do respond to oxygen therapy. Unlike the next topic, which is now ARDS, which is refractory to oxygen. So here, you simply support, this is all you can do because respiratory failure is a state, it's a condition, so you can only support it. The cure really is to treat the underlying condition. So tables 32-3 and table 32-2, you treat these conditions here and then you get rid of respiratory failure. Until then, all our treatment for respiratory failure is mainly supportive. It's only oxygen therapy. However, we achieve that depends on the patient's response. So we can try cannula first and then mask, rebreather, non-rebreather. We use non-invasive positive pressure ventilation, let's say CPAP, BiPAP, for instance. And if still not responding, then we go intubate the patient and put them on a ventilator. There's also a combined, one best example of a combined ventilatory and oxygenation failure is COPD. Remember, we have two types of COPD. We have emphysema and chronic bronchitis, right? So because of that, one is a ventilatory failure, meaning bronchitis, for instance. So you have airway is the problem, right? In chronic bronchitis, and then you have alveolar problem in emphysema because now there is hyperinflation of the lungs, of the alveoli. So there was damage to the alveolar capillary membrane due to changes in the COPD. So in this particular instance, COPD falls under both. So you have, it's combined. They have ventilatory and oxygenation failure. Another is cystic fibrosis, because in cystic fibrosis you have mucus both in the, not only in the GI tract but also in the airway. So the mucus is now so thick in the main bronchi all the way to the alveoli. So those two conditions fall under. Asthma also falls under combined because same thing. It's during an attack. So if during day to day, when they get these occasional attacks, it may be ventilatory, but during an exacerbation, it may progress into oxygenation failure. Like I said, the symptoms, of course, would be somebody who is really short of breath. So the only thing we can do here is to give oxygen. So there's nothing specific here. It's not no symptoms specifically for respiratory failure. It's somebody who just can't get any oxygen in or cannot get rid of CO2. So they'll have typical dyspnea. So sound looks like an asthma patient, looks like a COPD patient, looks like a PE patient. So look at the symptoms here. They're not really specific to respiratory failure. And as already mentioned, the only one we give is oxygen. And other supportive treatment, of course, is for just like any other patient with oxygenation problems. We give bronchodilators, we give steroids, we give analgesics for pain, we give hydration, what else? Suction as needed. We do what do you call the position? Postural drainage, increase fluids to liquefy secretions unless contraindicated. If there's an infection, again, depending on the underlying cause, we also treat the underlying cause. This is, of course, the underlying causes are not covered under Chapter 32. Any questions on respiratory failure? We'll discuss intubation and mechanical ventilation separately later tonight. Any question on respiratory failure? All right, let's move on to ARDS. By definition, thank you for reading, Mr. Racine.
Sure. Acute respiratory distress syndrome is acute respiratory failure with these features.
All right, pause for a minute. So it says acute respiratory failure. So does it have a PaO2 less than 60? Yes or no? Because it says here, it is respiratory failure. So does it have a PaO2 of less than 60?
Yeah.
Or does it have maybe a PaCO2 of over 45?
Yes.
Is the oxygen saturation less than 90?
Yeah.
Yes. So all the features of respiratory failure plus what? Continue, Mr. Christopher.
Sure. So we have hypoxemia that persists even when 100% oxygen is given. Refractory hypoxemia, a cardinal feature. We have decreased pulmonary compliance, dyspnea, non-cardiac associated bilateral pulmonary edema, dense pulmonary infiltrates on X-ray, ground glass appearance.
All right, so let's look at what happens here. Before I explain these features, let's look at the pathophysiology. Thank you. Read the whole paragraph for me, please. Thank you, Miss Deborah.
Despite different causes of ALI in ARDS, the trigger is a systematic inflammation response. As a result, ARDS, ARDS symptoms are similar regardless of the cause, and I can't see the other side of my screen. There's something, hold on, sorry. Okay. The site of the injury in the lung is the alveolar capillary membrane, which normally, I can't see that side for some reason, permeable only to small molecules. It can be injured during sepsis, pulmonary embolism, shock, aspiration, or inhalation injury. When injured, this membrane becomes more permeable to large molecules, which allows debris, proteins, can't read what's after that, fluid into the alveoli. Lung tissue normally remains relatively dry, but in, I guess, patterns, I'm not sure, with ARDS, lung fluid increases and contains more proteins. Sorry, guys.
All right, thank you so much.
Okay.
So the main problem here is acute lung injury, and I'll come back to this. Let me just show you the causes. We have a table here, 32-4. We have 2 rows. So we have shock, trauma, nervous system injury, pancreatitis, emboli, sepsis, and inhalation injuries. Then we have pulmonary aspiration, and then drowning. All right. So are these conditions in both row 1 and row 2, are they minor injuries?
No.
These are all serious, correct? So serious life-threatening injuries. So although they're not technically in the lung, except for maybe inhalation, and then we have pulmonary aspiration, you know, somebody vomited and aspirated gases, fluids with a pH of 3 or less, for instance, very acidic. But the others are not really, well, submersion, yes, that's also included. That would be direct lung injury. But the others aren't really affecting the lung, right? They are nowhere near the lung. However, they all cause acute lung injury, either directly or indirectly. Say, for instance, under trauma. Trauma will, of course, lead into hypovolemic shock. So that falls now under shock. In the case of nervous system injury, this could be spinal cord injury. In the pancreatitis is high risk for sepsis. And embolism, the same thing. Well, that would be in going into the lung. So yes, that is direct lung injury. Pulmonary infections, number one cause is pneumonia. And then sepsis, of course, will go into septic shock and so on. So these are severe injuries to the body. What they'll do is really cause the one I highlighted. It causes all of them when you have acute lung injury. This is the exact mechanism here. It says the main site of injury is here. And then because the lung tissues are full of vessels, full of capillaries, in fact, each alveolus is filled with, is wrapped in a capillary network, right? So let me illustrate. So imagine this is a blood vessel. This is a capillary. And this is a air sac. This is one alveolus. And this capillary wraps each of these 30 to 50 million of our alveoli. Now, in those conditions, trauma, sepsis, burn injury, inhalation injury, aspiration, etc., all those conditions are severe injuries. What they'll do is trigger a increased capillary membrane permeability because they trigger a severe inflammatory response. So all those conditions listed in whatever table that was, I forgot already, cause severe inflammation. And it happens to be systemic. So imagine each capillary, regardless of the location, because even though, let's say you had a pancreatitis, although that's technically in the GI tract, once it hits the bloodstream and the patient becomes septic, now the inflammation is now systemic, causing each single capillary to be leaky. So if the capillary membrane permeability increases, and as defined in that same paragraph that I highlighted, it said capillaries are normally impermeable to large molecules such as proteins, albumin. So now if the permeability increases, can albumin and other large molecules pass through or leak out of the bloodstream now?
Yeah.
Yes. So now as soon as the capillaries become leaky as a result of these inflammations, secondary to all those conditions we looked at in the table, now large debris like proteins, for instance, which are the largest molecules in the blood, in the plasma, now leak out. They enter wherever they can go. So one of those is because the very vascular lung is filled with capillaries all over. So these large molecules, these debris, mainly proteins and other particles, now escape. And of course, they will change the osmolarity of the compartment. So water usually follows albumin. So as albumin leaks out and enters the alveoli, water will go with it. So it will now attract debris plus water into the lung. Now, how can gas exchange if the lungs are wet? They're no longer dry, no longer air-filled, but now they are filled with water. The lung is now very wet. So this will now explain those features in the bullets in the definition up here. So now, how can gas exchange occur? No matter how much oxygen you put in there, if it's wet, can there be gas exchange?
No.
No, the water, the CO2 may be able to escape. You know how just like you can fart in the pool, right? You're swimming in the pool and you fart. Yeah, a fart can escape. However, can you fart into the pool? If you're up on the ledge, then you fart over the pool. Can you do that? Can the fart enter the pool? No, nothing can enter. You know, the same principle as with chest tubes. No, if you have a water seal there, you can't put gas to water. It's impossible. Water, I mean, air can escape from water, but it can't go the other way. So that's why you have, we call this refractory hypoxemia. No matter how many gallons of oxygen you give this patient, they will not respond. They cannot get the oxygen because the lung is now wet. It's no longer compliant. Compliance is the flexibility. Imagine a dry rag, a wash rag. If it's dry versus wet, which one is more pliable? The dry one, right? So the lungs are now filled with water. They are now less compliant. It's heavy. It's very hard to perfuse. If you put the perfusion will now be very difficult here because now it will increase afterload because the resistance, because there's full of water. So the patient on top of all this will also have heart failure, secondary to the decreased pulmonary compliance, specifically right side heart failure. Of course, that will result in dyspnea because the patient will be like drowning. Literally, the patient's drowning. And there's also a non-cardiac associated pulmonary edema. Now, they specify non-cardiac because on X-ray, when you take X-ray, a wet lung from ARDS and a wet lung from heart failure looks exactly the same. Now, how do we distinguish whether it's cardiac or non-cardiac? They will have to, the only way to know this is to put in a pulmonary artery catheter. Remember this from chapter 35, which was explained in chapter 38? If not, okay, let's discuss that again. So, in heart failure, how did the pulmonary edema form? How did water end up in the, let's say this is an alveolus here. This is the capillary. How did that water enter the lung in heart failure? Because we already explained how it entered the lung in ARDS. It was because of the increased capillary membrane permeability. So proteins leaked out and then water followed it, so they filled the alveoli. Here in heart failure, how did that water enter there? Was it the same way? Was there increased capillary membrane permeability in heart failure?
No. Is it because of the blood backup?
All right, because it was due to congestion. It was due to vessel congestion. So now because the heart failed, there's traffic here, traffic here, traffic here, traffic here. So in both cases, there's problems with movement of the blood. Forward flow is impaired, everything's impaired. So wherever they are, is stuck. So there's congestion inside the heart. There's also congestion in the lung. Congestion here in the superior vena cava, congestion here. All because this guy failed. So the reason for this water buildup here is hydrostatic pressure. Because of the congestion, so water pressure pushed water out and into the lung. So the only way really to distinguish is to put a pulmonary artery catheter here and see the readings. Now this was discussed in chapter 35. So what will be the readings, CVP or RA, right atrial pressure readings in heart failure versus in ARDS? And then on the left side also, PAWP, what will be the reading? So let's start with heart failure. In heart failure, what will these numbers be? High or low?
Increase.
Very high, indicating increased pressure here. Now let's go to ARDS. What will these numbers be?
Normal.
Normal or even low. Right, so that's the main difference. So when you read the non-cardiac pulmonary edema, that's what they're trying to say. If you put in a pulmonary artery catheter, the readings are totally normal or even low in ARDS. So you can distinguish, oh, this is not heart failure. This is from ARDS. And this one again is on X-ray. It may not look like this on day one. It will get worse. So every day the doctor will order a X-ray. So the chest X-ray, the appearance will go wider and wider. So ground glass. Have you seen ground glass? If you put ground glass into a container, what color is it?
Opacity, radio pack.
Yeah, white, right?
White.
Looks white, right? Lungs are supposed to look what on X-ray? The lung tissue, they're supposed to look, what color are they?
Black.
It's supposed to be black because they're air filled. Now it's water filled. That's why they look white. They look solid now. So that's what ground glass appearance looks like. So these are when you see all these, that's ARDS already. And remember, ARDS, just like respiratory failure, is not a primary disease. Something led to respiratory failure, something led to ARDS. And in the case of ARDS, these are your causes right here, table 32-4. You can now add COVID-19 here. COVID-19 leads to pneumonia, so that's now a pulmonary infection, and then you go septic, and then you have ARDS. And just like here also, so patients who aspirate, that's why we protect the patient from aspiration, especially the elderly or any unconscious, unresponsive patient. We take aspiration precautions, because imagine pouring down acid into down your lungs. Is that good?
No.
No. Acid can imagine, it can. Have you had chicharron? Yeah, chicharron is very hard, right? And your stomach acids can easily turn that into liquid. Imagine what your stomach acids will do to your lung if you pour it down there. Look at the mortality. This book is 2015, so the material found here is that old, and this one is 2016. The number then is 42%. Newer textbooks still say this is around 54%. So look at this, it's 2020. Look at our progress. We haven't made progress in treating ARDS, because that's the number one key there. But hopefully, it's true that what they're publishing in journals now regarding COVID-19, that they're responding to dexamethasone. ARDS doesn't really respond. The evidence up to today is still very controversial as far as using steroids in ARDS, because we're still trying to stop the increased capillary membrane permeability, that capillary leak syndrome. That's the problem there. We don't know how to stop it. There's no magic bullet to how the body reacts like that, which was really surprising when I heard about dexamethasone, because it's still a steroid, and this is really similar to COVID. How come COVID patients are responding to it? So this is all new. So since mortality is so high, our priority really is to catch it early. So the moment you see this patient already in respiratory failure, or having these already, meaning you give oxygen, they're not responding, so call your physician right away. So these are the patients admitted with these diagnoses here. These are the patients at risk for ARDS. So you monitor them closely for the condition. So we already have the signs and symptoms. They're further explained here, but the bullets earlier at the start of the paragraph on the definition are going to give you your signs and symptoms. Thank you for reading this. This is a trivia for ARDS, Miss Cindy.
Okay, so abnormal lung sounds are not heard on auscultation because the edema occurs first in the interstitial spaces and not in the airways.
All right. So the absence of crackles doesn't mean they don't have ARDS, okay? We already talked about this. So the whiteout appearance or ground glass appearance. And again, there's the hemodynamic monitoring here to distinguish cardiac from non-cardiac associated pulmonary edema. When they say here, no longer recommended, they're referring to the Swan catheter, the Swan-Ganz catheter, the pulmonary artery catheter. They're now going toward non-invasive hemodynamic monitoring, which is not really an exact science. Younger doctors are now using ultrasound, and they have a formula. I'm not familiar with the formula, how they measure the pressure and then to estimate the right atrial and the pulmonary artery pressures. Nothing still beats the Swan-Ganz, but again, they're trying to avoid using the invasive hemodynamic monitoring now. We won't test the phases. Let's go now to management. Management is just like respiratory failure, it's oxygen therapy. So if the patient, does this patient respond to oxygen?
No.
Okay, very good. So therefore, so what's the purpose of giving oxygen here if they're not responding?
None.
Actually, we can, but definitely non-invasive oxygen delivery here will be totally useless. The patient has to be intubated, and there is a ventilatory mode that can
Force it?
force it in. So that one is called, although it's not very popular, it's called PCIRV. This is pressure control inverse ratio ventilation. So what they do is normal inhalation to exhalation ratio is 1:1, right? Meaning this is inhalation to exhalation. You know, when you breathe, it takes 1 second to inhale, right? And then 1 second or maybe 1.5 seconds to exhale. That's the usual ratio. Because remember, the patient with ARDS has a poor compliance. Their lungs are very hard to ventilate because it's wet. You know, it's very stiff. So it's impossible. Well, not impossible, but it's difficult to ventilate it. So in COPD patients, they also have a very non-compliant lung because of the emphysema. Okay, so normally emphysema patients breathe with a ratio of 1:4, meaning they inhale for 1 second and then they exhale over 4 seconds. So that means this is called pursed lip breathing, if you remember this, right? So pursed lip breathing is how COPD patients breathe. So in ARDS patients, they now use inverse ratio. So instead of 1:4, what they'll do is 4:1. So the inhalation here, the air is forced in over 4 seconds, and then they'll let the patient exhale for 1 second. So imagine what will happen to all that water in there. So if air delivery from the vent is given over 4 seconds, what will happen to all this water here?
It'll get displaced.
Right, so the 4-second oxygen delivery will force this back into either the capillary or into the interstitial space, allowing oxygen gas exchange for just that short period. However, during the exhalation period, what will happen to that water? Will they stay out?
The water?
The water. Will the water stay out during the exhalation phase?
No.
It will come back,
They will
but no.
go, yeah, they will go back right. Yep, they'll go right back in because remember, there is still increased capillary membrane permeability.
Yeah.
So here, at least though, we have gas exchange here because otherwise it'll be impossible without this maneuver. So this vent mode will force the air, the oxygen in there, pushing the water out for just the period during the inhalation period. So we're forcing it out so that oxygen can perfuse inside for that small period. But then once the ventilator stops delivering the breath and then the patient exhales, water seeps right back in there. So until this period resolves, we will have this condition the whole time. Fortunately and unfortunately at the same time, this one will resolve eventually. We just need to keep the patient alive until this thing stops. All right, so as long as this, and we don't know, some patients have it for 24, 36 hours, some patients longer. So we don't know how each individual patient responds to the acute lung injury. So the duration of the increased capillary membrane permeability varies with each patient. So until then, you just need to support the patient, keep them alive until the whole thing resolves and hopefully they get discharged. And that is ARDS. Any questions? All right, let's take a break. Come back at 7:35.
Thank you.